Thanks for joining us for Part B, Dermatology, Common Rejections and Denials. This is a webinar designed for those who submit claims on the CMS 1500 claim form or the 837P Professional Electronic Equivalent. My name is Mary Mucko. I'm a specialist on the Provider Outreach and Education team at WPS GHA. I will be your host today. Assisting me is my friend and colleague, Ellen Barra. We include this disclaimer in all our education, and we do so to remind learners that although we made every effort to provide current information that is correct, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. And a final reminder shows on this slide that CMS prohibits recording of this presentation for profit-making purposes. So if you are recording this, please discontinue doing so, and please do not use any screen snaps throughout this presentation. You may have noticed in our advertisement that our agenda shows that this presentation really focuses on data. I'm talking about data today. In their internet-only manual, it's publication 100-09, Chapter 6, CMS instructs the MACs that we must analyze and provide education on claim submission errors. Now, claim submission errors include those that result in a rejected or denied claim. CMS also states that MACs shall maintain a provider data analysis program that produces a monthly list of the most frequent collective claim submission errors from all the providers in their jurisdiction. This program must include common and inadvertent clerical or administrative errors and also other types of errors that could be prevented through outreach and education. So for today's webinar, I advertised that I would discuss data for specialty 06 providers. Or 07 providers, I apologize. Topics I said I would cover include common rejections and denials. I'm going to talk about ways to fix those that are the most common rejections and denials based on that data. And I'm going to provide helpful resources that's going to help you fix or avoid the rejections and denials altogether. Finally, I advertised that I would answer questions about common rejections and denials that I am discussing today. So to fully understand rejections and denials, it's important to recognize the path that a claim takes, or what we like to call or refer to as the life of a claim. This is a simplified graphic, and this shows how a claim gets into our system. Of course, the service is provided, a claim is submitted. Sometimes the system rejects those claims. When that occurs, a 277 or 999 report is generated to explain why. This slide actually provides a description of claim submission. Most providers submit electronic claims. Very few providers actually qualify for a waiver under a law that actually prohibits Medicare payment of services or supplies when a provider does not bill to Medicare electronically. So in order to confirm claim receipt, providers should use the 999 report, and the provider should use the 277 report, which provides more specific information. Now, our electronic data interchange, or EDI staff, provides helpful information in a companion guide specifically designed to describe the data content requirements for an electronic claim. And I've included a link to that, or embedded a link here on this slide. So based on these reports, you will know if a batch is rejected and if you need to correct it and resubmit those claims. Here is a simplified graphic that shows what happens to claims that Medicare deems as unprocessable. Unprocessable really means rejection. It's really important for providers to understand that rejections are very, very different from denials. I think sometimes people, providers and people within their offices, and even people at WPS sometimes use these words interchangeably when they really shouldn't do that. A rejection is an unprocessable claim. It's never adjudicated. It is actually returned on what we like to call the front end before processing is performed. The reason for a rejection is that there's illogical or incorrect, even missing information on the claim. And because the claim is never processed, there are no appeal rights. What you need to do is fix it and resubmit it. Now, on a rejected claim, you will find on the remittance advice the remittance advice remark code MA130. And basically what that says is that your claim contains incomplete and or invalid information and no appeal rights are afforded because that claim is actually unprocessable. It goes on to tell you that you need to submit a new claim with the complete or correct information. On a rejected claim remit, you'll also find a CO16 group code, and that stands for contractual obligation. And that means that the patient is not liable for payment. The provider needs to fix it and resubmit it. A denied claim, on the other hand, is actually adjudicated. When claim lines or claims deny, it means that something failed to meet Medicare's payment criteria. It could be based on a law or what we call a statutory requirement. Perhaps the denial is due to not meeting medical necessity. Frequency parameters or utilization guidelines tied to a particular item or service are also a form of a medical necessity denial. Of course, other types of denials would include eligibility. Perhaps the beneficiary wasn't eligible for the service on the date of service, or it could be that the provider wasn't eligible. So on the remittance advice for denied claims, you will find, in most cases with very few exceptions, an MA01 code, and this provides for you the appeal rights. For denied services, patient liability is determined. Here then is a graphic that shows the path for a processed claim. The service is provided, the claim is submitted, and the claim line or claim in itself is either paid or denied, and the information will print out on the remittance advice. So let's talk about the remittance advice. I do want to talk about the importance of that document, that remittance advice, or RA. Sometimes we refer to this even as the remittance notice, and other people shorten it up a bit, just call it the remit. Now, most providers receive an electronic remittance advice, what we call an ERA, as opposed to a standard paper remittance or SPR. Now, depending on how the claim is processed, it might also include information about adjustments that are made to claims or even information about denials. It could also include information that that something is missing. Sometimes it even provides notice about refunds and offsets. That electronic remittance advice is also going to provide payment information about the transfer of funds and payment processing from a health plan to a healthcare provider's bank. Codes on the remittance advice provide information about the claim. Claim adjustment reason codes, CARCs, explain why a claim paid differently than billed, and remittance advice remark codes, or RARCs, provide more details about an adjustment that's described by a CARC. Another type of code that appears on the remittance advice is a group code, and these convey the financial responsibility for the unpaid portion of the claim balance. CO, I mentioned earlier, stands for contractual obligation. This means that the provider is liable and the provider cannot bill the patient. A PR, on the other hand, stands for patient responsibility, which means that the patient then is financially responsible. You can find code lists on the Washington Publishing Company's website. I included a link here for you to that website. It is that company, the WPC, that maintains codes for CMS, and you can find a link to their code lists, those RARCs, ZARCs, and group codes, for example, out on the Washington Publishing Company's website. I do want to add that we, WPS, understands that some of the codes that are used may be a little cryptic or may actually be kind of out of date. For example, some of those code messages include acronyms that are no longer being used by Medicare. They're out of date. I'll point those out to you a little bit later. Here are a couple of great resources if you are seeking information about the remittance advice or the RA. These are actually found on the CMS website, and I've embedded links here for you in the presentation materials. Next, I want to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim. And for those of you that are unfamiliar with the acronym MAC, what we call MAC, it stands for Medicare Administrative Contractor. WPS is the Medicare Administrative Contractor for Jurisdiction 5 and Jurisdiction 8. Jurisdiction 5, of course, is the states of Iowa, Kansas, Nebraska, and Missouri. Both Part A and Part B. In addition to those 4 states, there are states nationwide who have selected WPS for their Part A claims. So that is also included in the Jurisdiction 5 contract. Jurisdiction 8 includes Parts A and B for Indiana and Michigan. Now, after reviewing the remittance advice, a provider is going to need to choose the action to take. For an unprocessable or rejected claim, you'll need to fix the error and resubmit the claim. If the claim or claim line denied, there could be multiple actions that you can choose from, actually. You could simply resubmit the service, as I just mentioned. You might also be able to use a process called a clerical error reopening, or CER. CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. And I'll talk more about that CER process, CER process, later in this webinar. Another action to consider, of course, is an appeal. The remittance advice will provide the appeal rights when applicable. I'm going to talk about appeals a bit later on in this webinar also. Registered users of our transactional portal can render a clerical error reopening, use self-service to do that, or you can use that transactional portal to request an appeal. These self-service tools really do offer the most efficiencies. Our portal user manual provides illustrations and also step-by-step instructions on how to use all of the portal features, including the clerical error reopening and requesting an appeal. I want to talk a little bit more now about the clerical error reopening process. This is that process to correct human or mechanical errors. These are limited to errors in form and content, and these do not include failure to bill for certain items or services. The final bullet on this slide is actually an embedded link to a really helpful resource on our website. This particular resource, called How to Request a Clerical Error Reopening, provides examples of situations that can, as well as those situations that cannot be processed as a clerical error reopening. It also explains how to request a clerical error reopening via telephone or fax if you choose not to use the self-service function. And remember that self-service function for clerical error reopenings is included in the our transactional portal. And that portal manual, remember, includes the instructions for doing that. I want to give you some examples of clerical error submissions or clerical error reopening, those that are acceptable. This would include a mathematical or computational mistake. Perhaps there was a transposed procedure or even diagnosis code, inaccurate claim or data entry, misapplication of a fee schedule, or other computer errors. These are all examples of acceptable clerical error submissions. Now I want to talk about appeals for claim denials. I mentioned you most often can request an appeal. There's few exceptions where you cannot request an appeal. And the purpose really of the appeals process is to ensure the correct adjudication of claims. Physicians, suppliers, and beneficiaries all have the right to appeal claim determinations that are made by MACs. The beneficiary or the representative can request an appeal on any service processed for them. Providers and suppliers may appeal services for which they accepted assignment. For unassigned claims, however, providers and suppliers can act as the beneficiary's representative, but the beneficiary in that case would need to sign an authorization statement. One example of that is the CMS Form 1696, Appointment of Representative. In addition, providers or suppliers can request a redetermination on an unassigned claim if Medicare denied the service as not reasonable and necessary, or if the provider billed in excess of the limiting charge. And in that case, the provider or the supplier would need to refund any monies collected from the beneficiary in excess of that limiting charge. There are 5 levels of an appeal. There is only one level of appeal that's performed at the MAC level, and that is one that is called redeterminations. That is the first of 5 levels of appeal. All 5 levels have time limits to file the request. There are also time limits for completion that apply. There are there is a minimum amount in controversy that applies to levels 3 and level 5. You can combine like denials on more than one claim, more than one beneficiary, in order to reach that amount in controversy. And the amount in controversy, or the AIC, can fluctuate or change from one year to the next, so you need to keep an eye on that. There's some great resources available that provide much more information about appeals. We have, of course, our YouTube channel that has videos if you like to watch those. And a couple others that I've included here on your handout is the first one. It's How to Appeal a Claim Determination. This is a resource that is written by WPS and appears on our website, so it's specific to providers in J5 and J8, Jurisdiction 5 and Jurisdiction 8. And the other one listed here is a flow chart, and this is one of my personal favorites because you can see all 5 levels of appeal at a glance. You can see the time frames to submit those appeals. You can see the completion time frames that apply for each of those 5 levels. And it also shows the amounts in controversy on this particular flow chart. It is updated annually. It is on CMS's website. So if we're coming to the end of the year and you are using this particular flow chart or referencing it, make certain you're paying attention to when CMS updates that document, so that if those amounts in controversy change, you have the most current information based on your date of service, of course. All right, next on the agenda, the things that I said I was going to talk about today during this webinar. I want to talk a little bit about the data dashboard and how it is that I got the information or the data on common rejections that I'm going to provide for you today. So the next portion includes that discussion of data that I used to provide the most common rejections and denials for specialty 07. The data that I'm sharing today is all specialty 07 submitted claims for J5 and J8. So that means Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan all thrown together. While this dashboard that was created for people like Ellen and me in provider outreach and education to use, it really allows us to drill down not just by jurisdiction, but by specific state or even by specific county. But for today's webinar, I pulled data for our entire jurisdiction. For those of you that might be wondering what Specialty 07 is, it is a two-digit code assigned to WPS providers when they enroll. So during the enrollment process, or the application process, providers self-designate a specialty. CMS maintains the list of specialty codes, and while a provider can designate a secondary specialty or even other specialties, it is only that primary specialty, that one that was self-designated during enrollment, that is used during initial claim processing. Now, there are some situations where a provider will request an appeal and stipulate their secondary specialty in order for Medicare to make payment. Now, I pulled data for claim submission dates October 1, 2023 through March 23. That should be March 31. I apologize for that. That's a typo there. Not 23, but 31 of 2024. I guess it's correct on my slide. It's not correct on the speaker notes here that I pulled, so I apologize for that. The dates on this slide are correct. 10/1 of 23 through March 31 of 24. And the data was last refreshed on April 10 of 2024. And what that means is that any claims submitted for Specialty 07 dermatology claims after 4/10 of 24 won't be included in the data that I analyzed so that I could talk about those common rejections to you today. All right, so here then are listed the common rejections by reason code. What I'm talking about is that reason code that prints out on the remittance advice. There are numbers that you will see after each of the listed common rejections by reason, and this is the number of claims that rejected. We're talking about rejections now, or those claims that are called unprocessable. The most common rejection for dermatology claim is that the claim lacks information that's needed for adjudication. That means that there's information required to be on that CMS 1500 or the 837P that wasn't there when the claim was submitted. So that means that this claim will be kicked back to the provider or rejected, and you'll need to review that claim to see what it is that is missing and needed for adjudication. You'll need to fix it and resubmit it. Another common rejection, 458 of them for this time frame. The claim must be submitted to RRB, and RRB stands for the Railroad Retirement Board. So you can see that there's, a good number of claims that are submitted to WPS to process when the claim must be submitted to the Railroad Retirement Board, which is Palmetto GBA. In this case, you would need to prepare your claim and submit it then to Palmetto GBA. So how can you avoid this one? Look at the beneficiary's Medicare card when they present for services. If the beneficiary is a railroad retiree and has Railroad Retirement Board benefits for Medicare, it will show that on the bottom front side of their Medicare card. There's actually a banner across the bottom that reads Railroad Retirement Board. So then you'll know that you need to submit that claim to Palmetto GBA and not WPS. Now, of course, you can use other tools that I'm going to talk about later in this presentation to determine eligibility for your patients. The next common rejection is invalid or missing modifier. Check your claim over, check the CPT codes you're billing, check if there's policies for those procedures that will that require you to use a modifier. In most cases, you'll find that information in the coding and billing guidelines or that companion article for a particular policy. We do have quite a few fact sheets available on our website that cover many of the modifiers, most of the modifiers that are available. So you can find, for example, a modifier 25 fact sheet, a modifier TC fact sheet, and so on and so forth. So we have those available on our website, and I've included a link to those in the resource section of my presentation today. I'll get to those in a little bit. Missing information needed to adjudicate the claim. Very similar to the first bullet here, 392 denials. The next is CLIA number is invalid or missing. For those of you that are unfamiliar with that acronym, CLIA, and I did place these reject reasons on these slides exactly as they print out on the remit. CLIA stands for Clinical Laboratory Improvement Amendments of 1988, and this is a law that requires any facility performing examinations of human specimens, which would be tissue, blood, urine, for example, for diagnosis, prevention, or treatment purposes to be certified by the Secretary of the Department of Health and Human Services. And in this case, what we're talking about here is this claim, or the claims, 333 of them, were rejected because that CLIA number is invalid or missing from the claim. When you receive the certification for a particular lab service, and it's one that requires the CLIA number on the claim form, and there are lists of those labs that do and don't require listing on the claim. You do need to indicate that certification number, that CLIA number, on your claim form. So if it's invalid or missing, your claim will reject. You need to fix it and resubmit it. The next common rejection: missing, incomplete, invalid ordering primary identifier. Many services require an ordering provider. If that information is not on your claim, and it is a service that requires an ordering provider, then the claim will be deemed unprocessable. If it's missing or incomplete or invalid, make sure it's being keyed right. If it was keyed, if you did key something, make sure that it's complete. If it's missing altogether, you need to add it. All right, the first common rejection here on this particular slide is that the hospital needs to bill Part A for this particular item or service. So in that case, you would need to have the hospital bill. The service wouldn't be billed on the professional claim. The next common rejection is one that really kind of shows up on for all specialties, not just dermatology, and many of these that I'm talking about are actually applicable for other specialty types, not just for dermatology. But today we're talking about dermatology because that is the data that I pulled to present today. Field 11 of the HCFA 1500 must be completed, and you'll notice the first word in that common rejection reason is denied. So that's kind of one of those things that we can't change, only that Washington Publishing Company can change, but this is exactly how it prints out. Even though it's a rejected claim, it says denied. Also, look at that acronym there, HCFA. We haven't used that acronym in a number of years, Healthcare Financing Administration. We now use CMS, for Centers for Medicare and Medicaid Services. So this is what I was talking about earlier when I said some of these seem a little cryptic or even seem, or they're outdated, and obviously the HCFA is outdated. That field must be completed if you look at the crosswalk to the electronic claim, and I'll show you that in a little bit, or if you look at the CMS 1500 claim form instructions that are included in the internet-only manual. Links to these are provided, both of them, in the resource section of your handout. You will see that this is a required field. It needs to be filled out. If there is no other insurance that's primary to Medicare, because that's what this item 11 or field 11 is all about, is there another insurance primary to Medicare is the question. If there is none, you can't leave it blank. You have to put none. Okay, so that causes rejections in our claims system. The next one, facility lab name and address or PIN is missing. Within some of our policies, it states that you need to include the facility or the laboratory name on the claim form. I'm going to point that out to you in a little bit, a good example of it. The next one, this claim has been forwarded to Palmetto, RRB. So these situations, these 74 claims rejected, and we forwarded the claim onto Palmetto. You don't need to do it, or the provider doesn't need to do that. And this has to do with the trading partner agreements that particular insurers have with Medicare, have with WPS. Some claims we are in those trading partner agreements. Some of those agreements call for WPS to forward that claim versus the provider having to do it. Next, injection was denied because the name and dosage was missing. You need to provide that information. If you're using a not otherwise classified code for a drug or biological, you need to provide that information in item 19 or the electronic equivalent. Name of the drug, dosage, and so on. Place of service conflicts with procedure code. We have a place of service list out on our website. I know that one of my colleagues is soon hosting a place of service related webinar. So if you're interested in that, take a look at our live events webpage. But sometimes a particular procedure code, it's programmed within our claims processing system that this code can only be billed in these places of service. And that's exactly what happened here. If you question whether a procedure code can be billed in a place of service, you can pick up the phone and call customer service, but you do need to be careful how you're asking your question. You cannot provide a scenario about the patient has XYZ, their diagnosis is this, I'm billing this, can I bill it in the office? That's really a coding question versus asking Medicare, does your system accept CPT code 12345 with place of service 11? That's how you need to pose those questions. You can ask for coding advice because CMS prohibits us from giving coding advice, but we can tell you whether our system will accept this place of service with this CPT code. I talked a little bit about CLIA, that 10-digit certification number that needs to be placed on the claim form. I'm going back to the previous slide. I did include this when I talked about it earlier. It needs to be placed in item 23 of the claim form. And when I'm talking about here on this claim, facility and lab names and address, a referring lab is an independent lab that refers specimens to another lab known as a reference lab. When you are sending labs out and such, you need to include the lab's name, address, and zip code in the item 32 of the CMS 1500 form. So just some things to remember and helpful tips for you as you are avoiding these rejections in the future or fixing them. Here, I thought it would be interesting to pull not just those reasons for rejections, but the top codes. You can see there's a couple of evaluation and management codes that appear here. And for all of those reasons I just talked about, these are those common codes. So they kind of go hand in hand. Reasons for denial, or rejections rather, I just talked about. Now here are the codes. You can see that the Mohs surgery code there is listed. Both in I'm going to pull this over for a minute. I know that some of you were interested in some information about Mohs and you had some questions about it. And this particular webinar doesn't really go into the policy itself, but some of those rejections, some of them that I just talked about, can be avoided by looking at the policy. So here's the policy. It talks about the fact that there's special equipment and lab personnel required. There's qualifications to do this procedure itself. Here it talks about appropriate settings. Remember that some of the rejections are you can't do this CPT code in this place of service. So kind of all of it kind of correlates with what's here in the policy, qualifications, here are indications, and so on and so forth. But I think really the more helpful bit of information is not the policy itself, But the billing and coding article that accompanies this particular policy, L35494, if you're not aware or you're not familiar with billing and coding articles that are companion articles to our local coverage determinations, if you scroll to the near bottom of a policy, under associated documents, you're going to find a link to that billing and coding article. Okay, so in this case, we have a policy that outlines what Medicare, what WPS deems medically necessary uh, for Mohs surgery, what it is that needs to be documented in the record. And then, of course, we have that billing and coding article, and I have that ready too to save time. I went out and grabbed it before the webinar started. And here's that information that I told you would be helpful to avoid errors when submitting Mohs surgery CPT codes to Medicare. This talks about the modifier usage. I know some of you had questions about it. Talks specifically about using modifier 59. This coding companion article also talks about when this is being done with other lesion removal on the same day. This talks about the surgery codes that need to be reported with the appropriate quantities for the specimens mapped in the days and units field. Here is some information about the fact that you need to submit your primary code before you can submit the add-on code. This tells you that all surgical procedures performed in the same operative session must be reported on the same claim. So these are the guidelines you need to follow to avoid those rejections and denials that I just talked, or rejections that I just talked about. I haven't gotten to the denials yet. I'm getting ahead of myself. Here's the information about the procedure being performed on a completely separate lesion on the same date of service as another. And then here are the documentation requirements. This is what CMS or WPS rather would be looking for when we look at that documentation for medical review purposes. So some good information there within the policy. I want to go back to the listings of codes. I mentioned to you the Mohs surgery. There's other codes that appear here on the list. Biopsy procedures on the skin, destruction of benign skin lesion. Here's that J3590, which is the unclassified biologics administered by injection. And remember when I was talking about or identifying those top rejections and denials, you can really kind of almost pinpoint which go with which. For example, the J3590 is an unclassified biologic administered by injection, and that's hitting as one of the most commonly rejected codes. Well, the reason is because the name and the dosage was missing from the claim. You can see that listed here on this slide. So just kind of all goes together. Let's talk about denials now. These are the most common denials for dermatology claims submitted to WPS for those dates that I mentioned earlier when I talked about the dashboard and the data that I pulled for this webinar. Collection of fee-for-service during periods of managed care, 5,051 denials. What this means is that the claim was submitted to WPS when it should have been submitted to the beneficiary's Part A plan, or excuse me, Part C plan, the Medicare Advantaged plan. This is managed care patient. Again, this would be a situation where you would check eligibility, ask to see the patient's Medicare card to determine whether they have traditional AB Medicare that you would submit to WPS, or if there's a Medicare Part C or a Medicare Advantage plan that you need to submit the claim to. I do know that there are changes certain times of the year based on the beneficiary's choice, whether they want traditional Medicare or Medicare Advantage. You know, the best practice would be to ask to look at that card every time they present for services. And of course, you can use the eligibility tools we have, the IVR and the transactional portal, which I'm going to talk about in just a little bit. Next up, separate payment, not made for this service. Some of the services that are billed by dermatologists are bundled into another service. So you can't bill for this service separately because payment for the CPT or HCPCS code includes payment for all of the services connected. Um, Duplicate charge. You'll see duplicate charge already paid on that question mark 002XX is what prints out when we do this data pull. That a date would be filled in. A date would be filled in showing that this charge was already paid on this date on this particular claim. The second question mark 001 followed by those X's there would be the ICN of that particular claim. So a duplicate of a claim already processed. We also have situations where we have duplicate denials of claims now being processed. So that fourth bullet there means there's a claim within the claims processing system now being processed, which is a duplicate. We receive just scores, hundreds, thousands of duplicate claims every day. If you think, if you attach, let's say you attach a dollar amount to a claim that you prepare and submit to Medicare, and we attach a dollar amount to that claim that we reject or process. That's a lot of dollars that are unnecessarily being used. Um, if you use a billing service that on a regular basis just simply resubmits claims to Medicare because you haven't received payment yet, or the remittance advice, ask them to stop doing that. It is, or if you within your office do, resubmits every 30 days, for example, you need to stop doing that. It is considered an abuse. Next up, not covered when performed, referred, or ordered by this provider. One of the policies, or that policy I pulled up for the Mohs surgery, said only these kind of providers can render this service. This could be an example of a denial here. You would need to, of course, look at your remittance advice to determine. The service isn't covered when it's ordered by this particular provider. Make certain that you place the ordering provider number in there correctly. It identifies the correct ordering provider and so on and so forth. So just more ways to avoid denials such as that. Claim must be sent to the employer group health plan first, 1022 claims. That means that someone else is responsible for paying that claim before Medicare pays. So this is a Medicare secondary payer situation. We have a lot of resources available on our website. Our YouTube channel has a lot of videos that speaks to Medicare secondary payer. Next up, here's another duplicate charge. This is a duplicate. 1,000 more claims denied during this time period for duplicate reasons. We do have a resource out on our website that speaks about the various types of denials for Medicare and how you can avoid them. And one of the categories is duplicates. As you can see, we've had three different common denials by reason based on the data I pulled for dermatologists. This physician supplier is not eligible to receive payment. Here's a situation where the provider's not eligible. Maybe this is a situation where you would want to pick up the phone, call customer service. They would route you to someone in provider enrollment to verify eligibility dates and such. Maybe it was just something that you didn't submit the number correctly on the claim, but the physician supplier is not eligible to receive payment is another common denial for dermatologists. Pre-post-op care included in surgery, you may not bill the patient. This would be that 99204 code. As reporting purposes. It's no big surprise that this one actually hit the denials. Denied service and units of service are exceeded. This would be a situation where you'd want to check the medically unlikely edits that CMS publishes on their website. It's part of the National Correct Coding Initiative. In this case, the units of service exceed the MUE for that particular item of service. This is an appealable denial. You can submit medical record documentation to justify payment. If you have that in your records, in that case, you'd want to submit an appeal, and Medicare would make a decision on whether any of those excess units, any or all, could be payable. So here then is a look at the common denials by HCPCS and CPT code for those reasons I just talked about. You'll see 17,000. This is the destruction procedures on benign or premalignant lesion of skin. 88,305, of course, is the pathology service, and sometimes payment for this service is not separate. Another thing that might apply here would be maybe you build it for a managed care beneficiary. Maybe it's a duplicate. Maybe this was denied because it's not covered when performed, referred, or ordered by this particular provider. So different reasons could apply for or to the denials we're seeing for that code. The 992024, of course, is that global post-op visit. 17110, this is a situation where the code should be reported with 1 unit of service for up to 14 lesions, and CPT code 17111 is also reported with 1 unit of service, but that represents 15 or more lesions. So this may be the CPT code that's problematic, leading to those MUE denials that I just talked about, where the units of service are exceeded. The guidelines state it's 1 unit of service for those. 11102 is a code that would perhaps pertain to those codes being submitted for managed care beneficiaries, might be denied due to duplicate reasons, maybe units of service are exceeded, or maybe even this claim might be might need to be sent to the employer group health plan. So a number of reasons why that one can be denying. And I actually pulled the data for these codes to check what those top denials were for these codes. For the MOSE code 17311, this is being denied most often because providers not enrolled in the CLIA program, and they need to do so. Duplicate charges on paid claims, duplicate charges on claims now being processed, managed care, and services billed are beyond the scope of the CLIA certificate. So again, all kinds of things that you can check into that would be reasons for that code denying. All right. I mentioned to you that I actually pulled some data for some of these codes that I'm talking about here so that I could give you the reasons why these codes denied. And most of them, of course, are those denials that I've already listed by reason code. But in addition to pulling by reason, you know, we can really drill down, or by code, we can really drill that data down even more on that dashboard that we use. And it is simply just we just fill in codes and specialties and or states or counties, and it just like that, the data comes back to us. It's almost instant. We can narrow down state by HCPCS code, county by HCPCS code, and you know, state and county, and trending. That last one I haven't talked about yet, but I do want to talk about it. I mentioned to you that CMS requires that we monitor the data to see why claims are rejecting, why they're denying, and then CMS expects that we provide education to avoid those in the future. And here is a trend that I wanted to share with you just as an example. This is a data trend for a denial. This is the coded description prints out claim previously paid or may be paid under EGHP, Employer Group Health Plan, through disability. So it's another type of insurance that's part of that Medicare secondary program. In this trending report that we can pull, it shows us the claim count for the current 3 months was 42. For the prior 3 months was only 6. And the difference in the number of claims is 36. So this particular denial, the percentage change for this denial reason was 600% over this 3-month period. And then this last bullet here just shows you that there's a visual we can look at in these trending reports, and it would be just an arrow up, which would show red because we don't want our denials or rejections to increase, or an arrow down, which would be the decrease. And that shows up in green, but in this case it went up 600%, so the arrow went up. All right, that is the actual data portion of this presentation, part of which I advertised I would share with you today. Here then are those resources, or sometimes I call them tools, to help you avoid these or fix them. This is the requirements for Medicare claims, and I did mention to you earlier that we have the claim form instructions. There's the link to that there in Chapter 26, and then this 1500 claim to the ANSI 837-5010 electronic claim crosswalk. I want to show you where to find that because I think it's a great tool. Out on the WPS, I've linked to it in your handout, but on the WPS website under quick links, EDI is right here. It's our electronic data interchange. And when you go to that page and scroll down, you'll see on the far left is our Medicare EDI. Here is where you can find those companion guides I talked about very early in my presentation, the 999, the 277. But here, this crosswalk, and I'll open it quickly here, this is a crosswalk from a paper claim to an electronic claim. So for example, what you're seeing here is it prints out in columns. If it goes in item 14 of the paper claim form, this is where you need to put it on the electronic claim. I'm going to go back, shrink it up a little bit here so you can see it all. So I like to talk about item 19 because item 19 is used to put a lot of information in. So this speaks to the different information that you need to report in item 19 depending on your claim. But if it goes in item 19 on the paper claim form, this tells you the data element description and where you need to put it, the loop, and so on and so forth on the electronic claim. It also tells you the requirements. What is it you need to put in item 18? You'll notice the S in the status column. You'll notice also an R sometimes in the status column. At the bottom of each page, it tells you that an R means that it's a required data element needed in order to process the claim. In other words, if it's missing, your claim is going to be rejected. It's unprocessable. And S means a data element that's situational. It's completed if other conditions exist. So one of my favorite tools that I like to show off during these presentations, this is a resource on our website that speaks to rejected claims, how to fix them. We list these by remark codes. Remember those remittance advice remark codes that I talked about early on that tell you why a claim denied. Common claim denials. This is our resource on our website that lists various categories of denials. I mentioned to you earlier, I was going to show you, here's where you can find those reason and remark codes that are denials for duplicate claims. We've categorized our denials out on this resource: bundling, entitlement, global surgery, so on and so forth. So for each of these categories, you'll find reason and remark codes. It tells you how to avoid it, what you need to do, or what you need to submit for your appeal. Here are additional resources. You can see the MSP questions and answers here, live events webpage. That's what's coming. This is where you're going to find that webinar that will, if it's not already, it will soon be advertised, that place of service webinar that one of my colleagues is hosting. Encore presentations are recordings of our live events. The LCD and article lookup tool is a handy tool that I do want to show you quickly. I know I'm getting close to time here and I apologize for that. LCD and article lookup is located on our homepage. This is where you can put in a CPT code to see if there is a policy for that particular code. It matches by title of the LCD or information that appears in the article, that companion article. So if there's matches, it'll show here. Okay, I'm just putting in a couple of numbers just to test it out and show you. I didn't find anything that matched though. All right, Medicare Advantage, that's for those situations where the patient is a Part C beneficiary. They have chosen Medicare Advantage. Those medically unlikely edits are part of the National Correct Coding Initiative. These are those denials when the MUE exceeds the published MUE, or the units of service exceed the published MUE. Not all MUEs are published. Some are confidential and don't appear on the list. This is one of those tools that I talked about where you can find eligibility information. It's our interactive voice response system. I know one of my colleagues is currently doing some education about the IVR and all of the great information you can get from it and how easy it is. We do have an IVR operating guide available that tells you how to easily use this tool, available 24 hours a day, 7 days a week. It does have limited functionality outside normal business hours. This is the tool you can use your voice or telephone keypad. I've talked about our transactional portal. This is where you can get eligibility, claim status, claim details, same as the IVR, 24 hours a day, 7 days a week with limited functionality. We have that portal user manual available. I have included the link, but if you're ever out on our website and you want to quickly get to the portal user manual, any page of our website has this user logon or login box here where you can get to the secure portion of our website that we call the transactional portal. Right here under this box that says login is a link to the portal user manual. This is where you will find illustrations and step-by-step instructions for using all of the functionalities of the transactional portal, such as that clerical error reopening process that I talked about. One last thing here before I get wrapping things up. I do want to share this with you because CMS is asking us to do so. For anyone that is tasked with provider enrollment at your business entity, CMS and Noridian Healthcare Solutions is teaming up to host an annual National Provider Enrollment Conference. You can see the purposes listed here on this slide. It is being held on the 28th and 29th of August. It is free. It will be held in San Diego. The times for this, the schedule is available. Descriptions are available of the breakout sessions out on the CMS website. And I'll have Ellen put the link in the chat box for you where you can get to the information about this particular conference that's coming up. CMS invites you to attend. All right, and this time we've only got a couple of minutes left, so I do want to apologize that this ran long. There was a lot of information covered today. I told you we were going to talk about rejections and denials, the data. What are the reasons? Why are these claims rejecting? Why are they denying? How you can fix them, how you can avoid them. Now, I will tell you in just a couple of minutes how you can send your questions to me following this event. Our greatest compliment is when you recommend our education to others. Please consider doing so. This really helps us reach the greater provider community, and it helps us reach our goal to assure that current and effective education is being provided for all of those in our MAC jurisdiction. On behalf of myself and Ellen, who's been helping out today, and Provider Outreach and Education, I want to thank you for your participation. We look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect.